everyone, and welcome to our webinar this evening on the 2-week wait. I'm Kate from Fertility Network, and this evening we're joined by Ephia Yasmin, who's a consultant and fertility specialist from University College London Hospital, Debbie Evans, who's the Director of Nursing and Clinical Services at Herts and Essex Fertility Centre, and Deborah Howe, who's a specialist fertility counsellor. We wanted to do this webinar because we know that the 2-week wait is one of the most difficult times during treatment, and we wanted to give you some reassurances because we know that people often really worry about what they should and what they shouldn't do. The webinar is being recorded and it will be available on our YouTube channel within the next few days, and we'll post the link on our website and our social media when it's there. We've had quite a few questions submitted in advance, but if you have questions as we go along, do just pop them in the chat box. And I think it's easier if it's okay with you to put them in the chat box rather than the Q&A, and we'll get through as many as we can. We're going to start off with a brief introduction to each of our panelists this evening, and they're going to tell you a little bit about themselves and what they think matters about the 2-week wait. Deborah Howe, we're going to come to you first, if that's okay.
Okay, hello, thank you, Kate, and welcome everybody. A privilege to be here. As I say, my name's Deborah Howe. I'm a fertility counsellor at the Centre for Reproductive Medicine, UHCW in Coventry. I support individuals and couples going through treatment at various stages. I have a real empathy and passion for people who are going through that 2-week wait, in terms of how people survive it, and what they can do to support themselves and each other in order to get through all of that. And yes, just wanted to really thank you all for attending today, and hopefully we'll have some of the questions that you've got answered as part of this webinar.
Thanks very much, Deborah. Debbie Evans.
So I'll mute myself. Good evening, everyone, and thank you, Kate and Fertility Network, for inviting me tonight. The 2-week wait, it's a scenario that baffles us in the clinics, and sometimes we can't get it right all of the time. But the key message that I want to get across to all of you tonight is that there's no right or wrong way of how you manage that 2-week wait. But hopefully tonight you're going to get some hints and pickups on how we can perhaps support you differently, or answer some of those questions that are going to clear up some of those nuances that are bugging you around what you should or shouldn't do in that 2-week period. So thank you again, Kate and Fertility Network, for having us here tonight.
Thanks, Debbie, and thanks for joining us. Ephia, I wanted to come to you next, and I wondered if you could maybe start by just explaining to everyone what's actually going on in your body during the 2-week wait, to kind of frame it, because I think that might be helpful.
So once again, I echo my colleagues here in thanking Fertility Network UK. And I am Ephia Yasmin. I'm a consultant at University College London Hospital and the Centre for Reproductive and Genetic Health. And yes, I'm a clinician. And actually, you see, we do a lot of work before and during treatment. And I have to say, from a clinical perspective, I think we tend to leave you alone, don't we, for those 2 weeks. And we are conscious, therefore, that during this time, suddenly from having a lot of many clinical encounters, opportunities to talk, suddenly you may feel a bit alone in the 2-week wait. And during this time also, we appreciated that there may be several questions going through your mind. So I would like to talk to you a little bit about actually what's going on inside, or what could be. So after the embryo transfer, we would expect certain events to take place. Now, this also depends on what state embryo or what stage of embryo transplant you had. So for example, if you had a day 3 embryo transplantation, then actually there wouldn't be implantation straight away, because it's only the blastocyst, which is the day 5 or day 6 stage of embryo development, that can implant. When we say implantation, it almost suggests a very active role of the embryo to go and implant. But actually, it's a conversation that happens between the embryo and, very crucially, the lining. And actually, it is a lining that kind of goes through changes under the signals coming from the embryo and engulfs the embryo if implantation were to take place. Now, sadly, implantation may not take place, and as we know from the success rates of IVF, that in more cases, and especially in as we get older, actually fewer, in proportion, there'll be fewer implantations, and there'll be a higher proportion that actually wouldn't implant. And as I was saying, this implantation or a lack of implantation would happen if all those events, you see, everything has to happen just so, and there is very little we can do to control. But what clinicians do is to already create an environment conducive to this embedding, but that preparation had already taken place. That means after embryo transplantation, apart from keeping up with the medication, there isn't much we can do because that step is left to nature. But as I said, all we can do is make sure that we have paid attention to detail up to that point to make sure you've had the embryo transfer at the right time. So if an implantation does occur, then what happens? You see, this is a stage of rapid cell development. After egg collection, so egg collection is like having ovulation. So after ovulation, you get a lot of progesterone in your system. And that's why, even in menstrual cycles, we feel differently in the second half of the cycle. And when having any fertility treatment, there is, in a fresh cycle, some production of progesterone of our own, but also the progesterone that is replaced or given additionally, supplemented. In medicated frozen embryo transfer, where we are not relying on your own ovulation, then all progesterone will come from the medication that you are given. So that will carry on in the background, okay? But if there's implantation, there will be higher levels of progesterone, and some of these cells that implant will eventually form the placenta. They are called trophoblasts. They will start secreting human chorionic gonadotropin, or HCG, that eventually leads to what you find as positive in a pregnancy test. So to remember, actually it's not the fetus. It's not the fetus releasing this hormone. It is actually these cells that would eventually form the placenta. In a fresh cycle, some of the HCG might still be there in the background from having had the trigger injection with an HCG. So it is important to remember that, okay? Just to enable you to understand that doing pregnancy tests too early is going to be giving you some false positives. So if there was a implantation, so this process will carry on, and the lining will remain conducive. So a lot of changes will happen in the lining, and sometimes there may be a bit of spotting. So sometimes women experience a little bit of spotting and may become quite worried, but that just might be due to the hormonal changes taking place, and either some blood vessels just leaking, breaking, say in the cervix, or a little bit of endometrium shedding. The endometrium after implantation changes into what we call decidua. So it's a different type of endometrium, okay, very spongy, very good for the embryo. And of course, if an embryo has implanted securely, then you will find that the pregnancy test is positive. Now, the pregnancy test kits are very, very sensitive, and they pick up quite low levels of HCG. And why 2 weeks? This is again a question. Why not earlier, especially if you had a blastocyst transfer? Why not test earlier? Because implantation after a day 5 stage embryo or a day 6 stage embryo will be soon after. It'll be in 24 hours or max 48 hours. It'll be done. And slowly HCG will start getting secreted. That is because we would rather we allow enough time for the hormone to build up, because doing too early, as I said, would either give false negatives or false positives. Okay, so there isn't much to be gained by doing too early. And 2 weeks is kind of a little bit sort of arbitrary, easy to calculate, and also helps us, very crucially, kind of determine if the levels of HCG we are seeing, if we do HCG levels and do progesterone levels, whether they are correlating with that 14-day period. So, and if unfortunately there is no pregnancy and therefore all these events are not happening, you will find a lower level of progesterone. So a lot of people feel very concerned if they have measured progesterone later on in their 2-week wait, and sometimes maybe a week before or 5 days before their expected testing time, they find a low level of progesterone and they think their body is not producing, and that is what led to the lack of implantation. No, it's usually the other way around. The absence of implantation allowed the progesterone to fall. Okay, so that's kind of how it works. And some women notice, therefore, the shedding of the lining even before they stopped their own progesterone, that is the medication of progesterone, but some only have withdrawal bleeding after they stop their progesterone. So that is kind of in a nutshell about kind of from a science perspective, what is happening and what's also being contributed by the medication that you're receiving.
Thanks, Ephia. We did have a question that's relevant to that, so I shall ask you it now, which is, what's a good day 21 progesterone level, and can that indicate likely pregnancy?
Yes, and it is $1 million question in the sense we know what the lower limit is, okay, but we don't know what is an absolute kind of upper limit of what we would consider to be normal or good prognosis. Now, as long as progesterone is more than 30, it also depends on obviously the unit of measurement. That's also very crucial. Then that is enough to sustain a pregnancy. So where did this number come from? This is from looking at, day 21 progesterone, let's say from ovulation-inducing cycles. Ovulation induction means where, you're receiving medication just for the release of one egg. And if there is a pregnancy, so then we can correlate, because women who have ovulation induction often get progesterone level measured after their ovulation to see whether they have ovulated as a measure of ovulation. Now, then what other levels should we be looking at? So there are several cutoffs, so 60, 70, 80, 90, 100, and different clinics set different targets. In general, a level of progesterone at the upper end bodes well, okay? Because at the lower end, you get this ambiguity, will it, will it not? But at the upper end, you've got this kind of sort of reassurance that these are good levels. There is some evidence that, especially in frozen embryo transfer cycles, that higher levels of progesterone are associated. It's very important to understand association and causation, because most studies are about association. Doesn't mean that cause, but yes, higher levels are associated. And these higher levels means 90s and 100s. So I hope that answers. I know it's not a straightforward yes or no binary black and white, but it's all in the context of kind of when you are measuring. So yes, a day 21 progesterone measurement and what is linked with hopefully a positive outcome also depends, therefore, on what type of treatment you're having and what is being supplemented.
Thanks, Ephia. That's a very comprehensive answer. The next question we had, I think, is probably for Deborah Howe, from someone who had an IVF cycle earlier this year, which was unsuccessful. They said they were really stressed and anxious all the way through and didn't seem to be able to stop themselves feeling that way, and is now sure that the fact that they were so anxious and stressed had something to do with the IVF not working. And we're saying they're terrified of the same thing happening again. Is there anything they can do to stop feeling so anxious, Deborah?
And thank you, Kate. Anxiety is a massive part of fertility treatment in terms of what we expect and what we hope, and our biggest fears are of treatment not working. potentially it is the management of anxiety and the management of stress, whilst we know that we can't eradicate it completely. So for me, when I speak with the ladies, the couples, and the individuals that I work with and speak to, it's about recognizing that they are going to be stressed and they are going to be anxious, but it's how we manage that. To try and eliminate it completely wouldn't be feasible. So and potentially the fear and the anxiety is about that kind of fortune telling about the outcome of treatment, not necessarily about the here and now. So a lot of the practices that are kind of suggested are keeping us in the here and now, which I appreciate can be very difficult. So it's about recognizing what our breathing's doing. Are we shallow breathing? Are there signs and symptoms in our body in terms of feeling tense in the stomach? Are we feeling tense in the shoulders? It's paying very close attention to what our body's telling us and to be able to manage those. So breathing is always important, but actually taking the deeper breaths are important. Trying to build in time for yourself and actually to be very gentle with yourselves and very kind to yourselves, knowing that you're absolutely doing the best that you can do in order to achieve a pregnancy. Now, sometimes I hear there's a kind of a harshness in terms of that, and sometimes it doesn't feel easy to be able to do that. Communication is very important, and where there are couples who are in relationships, being able to speak openly and freely about how one's feeling is important. And often we need to continually speak about how we're thinking and how we're feeling, depending upon how that's received. Sometimes we can have it received with a practical, and sometimes we can have that received with, it's okay, it sounds really tough. And I think dependent upon what we want, if we want the practical, it's going to be okay, that can then soothe. But if we're wanting the sense of, yes, it's really tough at the moment, and we don't get that, sometimes we can then become frustrated and angry. So it's very important to look about our communication channels and speaking with others. Sometimes we can sort of distract, and that can work for a little bit, whether we distract ourselves by watching, I don't know, Netflix, a box set where we don't really have to think, that can be very good. Sometimes we can sort of connect with nature and go for that walk in the fresh, whether it's sunny or raining. Sometimes for some of us, that's a real connection and a grounding. It's about things doing with sort of intentional mindfulness so that we bring ourselves back into the here and now. Obviously, within the centres, I would hope you've got access to a counsellor. And so sometimes, you know, making that appointment to speak to a counsellor, where it is a confidential, free space to really talk about how you're feeling and what your thoughts are without having to potentially be guarded about minding other people's thoughts and feelings. Sometimes we don't want to open up, do we? We don't really want other people to absolutely know how we're feeling. I think there's so many little bits of a jigsaw that we can use in terms of managing stress and anxiety that I couldn't potentially say that if you do this, it will alleviate your anxiety, because we're also individual. A lot of people do refer to exercise and keeping fit. And for some people, it's a very important sense of like release, isn't it, of emotions. And whilst again, there isn't anything that I can particularly say, as I think Ephia said, in terms of good or bad, it's about trying to maybe for 2 weeks think of something that you could do that would help to reduce stress. While it might not be the same kind of HIIT activity or marathon that you would normally run, we're just trying to manage that emotion in that period of time.
Thanks, Deborah. That's really helpful. Debbie, we've got some questions coming up at the moment, and we had a few earlier actually about pregnancy symptoms and how early you might expect them. Someone's asked here about whether it's a sign that your breasts start to hurt less. Does that mean your progesterone's dropping? And saying they find it very hard interpreting symptoms in the body and predicting what's happening. I mean, what would you have to say about pregnancy symptoms, Debbie?
That's a really difficult one, because all of our bodies react in different ways and at different times of our cycles. I think both Ephia and Deborah have both alluded to it. Listen to your body. Just listen to what physically you know is happening to your body. You know your body best. You know, we get lots of calls through the clinic. You know, I had my embryo transfer 3 days ago and I'm now feeling pregnant. And is that correct? You know, Effie has given you a little bit of the biology, the science behind it. You know, the physical ability for your body to be reacting in that way is not really happening. But it's our coping mechanisms. It's our, you know, control of everything that you've just been through. Your run up to your fertility treatment, your egg collection, your embryo transfer, and now this is your control thing that you want to feel, okay, yes, this is going to work, and this is how I need to feel, and so this is how I am feeling. And sometimes that's really difficult from a nursing or medical perspective to say, actually, no, that's impossible. You can't be feeling that just now, because we do know that people do feel those symptoms, and that's okay too. But it's how we interpret them and how we have the expectation that we need to follow the guideline. We need to follow what's physically happening in our bodies to be real, and to control, in what Deborah is saying, in how we control the anxiety or the reassurance that we need that, am I pregnant 3 days after my embryo transfer? No, that's physically not practical, not possible to be feeling like that now, but that's how you're interpreting it, and that is okay. It's just how we manage those feelings. You know, trying to do tests too early because I know I feel pregnant is not going to help, because you're going to get that false positive or that false negative that is going to change if you wait the 10 days later and do the test at the proper time. So we talk about it so much in this 2 week wait, and we fully, you know, sit with you and understand what might be going on with you at home. But you're all different. You're all going to be coping with this in a very different way. There's no right or wrong. I said that at the very beginning, you know, how we manage what is physically happening and the expectations that we have from this rocky road that you've just been on, because trust me, it really is a rocky road that you've been on just to get to this point. And now those high expectations of, wow, I've done it, I've got here, now I've just got to get through this next 2 weeks. And, you know, as I said, there's no right or wrong. Just be in that best physical and emotional state to help you deal with everything that's going to happen within that 2 week period.
So someone's just asked a question of whether it's possible to have no symptoms at all in the 2 week wait. And I think that's exactly what you've just said.
Absolutely.
They're also saying, is it possible for the brain to produce symptoms? And I think the answer to that is probably yes, most definitely. But
Yeah.
Effie, I think you wanted to just come in. Did you have something to add?
Yes, I was just going to say that actually most of those pregnancy symptoms that we attribute to a pregnancy, such as breast tenderness, feeling a little bit out of sorts, that's due to progesterone. Okay, so as there's progesterone in the system, there will be these symptoms. Or, again, as Debbie said, different individuals will respond differently to the same level of hormones. And it also depends on what we call, hormonal interaction is based on what we call receptors. That means if we give, let's say, 100, a level of 100 or a dose of 100 to 10 women, they will all, number one, absorb slightly differently, but also at the receptor level, they will have different receptors that will accept that hormone, okay? But there is wide margin of error. So it's like we don't have to be, you know, totally kind of obsessed with exact numbers, number one. And yeah, so, and then there is a huge variation. And if I may just, because we are on progesterone, and not to be too worried about dropping or rising, because remember, we are measuring in the laboratory with the help of reagents. So if I measure somebody's progesterone 3 times during the day, I will get a slightly different result. Okay, so these are very broad assessments. I just wanted to clarify that about early pregnancy symptoms that are mostly due to progesterone.
Thanks, Ephia. Just one answer to a question that someone's just put, is this being recorded? Yes, it is, and you can find it on our website later on, and we'll post on social media where you can find it. It'll be on our webinars page. Now, Ephia, we've had an awful lot of questions about one thing, which I wanted to talk to you about, which was about exercise. I mean, so many questions about it. So one person wanting to know if they can run and go to the gym, one person asking about paddleboarding. We've had someone else asking what's a normal level of physical activity, because there are so many do's and don'ts, and someone else actually asking about sexual activity as well and whether that's okay in the 2-week wait after IUI. I wonder if you could address that, because it seems to be one of those huge concerns to so many people, exercise.
Thanks. Yes, often asked, and it is a commonly asked question, frequently asked questions in the clinical setting. So the straightforward answer is, you can carry on doing what you usually do. So that's the straightforward, but within reason, okay? So because what you're trying to do is, kind of conserve some energy. Every cell of our body needs oxygen and the energy to do what it's supposed to do, okay? So you want to not divert, all this energy into kind of one location only. So whilst it may not be a great idea to prepare for a marathon, but of course, running, and you know your body, as Debbie said, you know your body and what your limits are, where your heart rate remains stable, you're not out of breath, your blood pressure is not going to be all over the place. So what you're used to doing, you could do, okay? And as long as you stay quite comfortable. And in fact, I will say is, it's not a great idea to be totally sedentary. That is not. So think about natural conceptions. Here, this assisted conception means we are assisting with certain elements of conception. Okay, and but there is a huge amount of there's natural processes that will be going on, and it is absolutely necessary. So just like anybody else who is attempting to get pregnant will not stop doing what they're doing. Okay, so it's not something we can control to that extent. So careful exercise, as long as you're doing it within your own limits, is the right answer. So paddleboarding. Now, of course, that's absolutely fine. I do not see any problems paddleboarding, but if you're learning for the first time, or if you're trying to do something for the first time, that may, cause a bit of a problem in terms of making you vulnerable to injury. That wouldn't be a great idea, because you don't want an injury if you were pregnant or in preparation for pregnancy, because that would mean, some care, analgesia, etc., etc. So it's all about more about thinking it through from a very common sense perspective rather than something scientific. And there's been no scientific study to say only this amount of exercise is, associated with better pregnancy rates, or just lying down or being, upside down, nothing of that sort. Just regular, normal activity is the straightforward answer.
We had another question about yoga. So yoga presumably would be fine. Any kind of gentle exercise, absolutely fine.
Absolutely fine. And can I just add, because I think people think about positions, Remember, so first of all, the embryo cannot fall out. It's not gravity. It's not, subject to gravity where it is in a receptacle and it will fall out. No. And also, the uterus in the standing position is actually this way. It's tilted forward. The vagina is tilted backwards, and it's at an angle anyway. So even without that, even if it was straight, it's not going to fall out. And therefore, if it involved a little bit of jumping, doesn't mean, there's something that you can dislodge an embryo. Uterus, and also, uterine muscle is what we call involuntary, just like the heart muscle. So there are muscles we can contract. We can contract abdominal muscles. We can squeeze. We can contract these muscles. But we cannot voluntarily affect the contraction of our heart or our stomach. Yes, if we put food in, it will do its own thing in response. Similarly, in the uterus, just by, if you did a little bit of abdominal exercise, doesn't mean that you're contracting the uterus and you're going to do damage, nothing of that sort.
Thanks, that's very reassuring. Debbie Evans, we had a few questions about supplements and food. So one person asking what supplements they should take or avoid, someone else asking whether there are foods they should avoid, and someone else asking a related question about whether, and I know there's quite a lot online about this, whether you need to stay warm in the 2-week wait, wearing socks and there's quite a lot about eating only warm foods. I wonder if you would be okay to answer that one.
I think getting yourself in the best physical shape, physically and mentally, before you start on your fertility journey is that best place to be. And that includes your diet, eating a well-balanced, healthy diet. There's no gimmicks, and there shouldn't be any gimmicks. Don't go out and spend hundreds of pounds on potions and lotions and pills that are going to promise the earth and going to promise you a pregnancy at the end. Honestly, it is all about that, the best, healthiest diet that you can eat. And that's for both of you, for both the partners, to get yourself into that. Yes, we have all these fallacies about eating pineapple and drinking lots of milk, and there is no clinical evidence for any of these to suggest or sustain that these are going to support you getting pregnant or indeed supporting a pregnancy. So please don't get embroiled into these things that are going to cost you a fortune and give you promises that they're never going to keep. Supplement-wise, the most key supplement that you should be taking when you're preparing for pregnancy is folic acid, and that is key. There are some very good supplements for prenatal and for when you start to get pregnant. But again, don't spend a fortune. Go to your local chemist and you'll see that they're going to give you the healthy natural vitamins. But if you're eating a healthy, well-balanced diet, you will get all the nutrition that you need. And I think that's really key. Just get yourself into the best fit for fertility state that you can be, including emotional and physical. Your diet, gentle exercise. Don't suddenly go out and start something new, as Ephia says. Just recently I had an aerobic instructor who is doing 35 classes a week. And she said, oh my God, it's my job. Can I still do my exercises? Yes, of course you can. And, should I be eating anything differently? No, you shouldn't be eating. Do exactly what you're doing to get yourself into that best physical state. There's no wacky gimmicks.
Thanks, Deborah. I think that's a really important message.
Yeah.
Deborah, sorry, coming back to you, we had a question for Deborah Howe about any tips on dealing with the emotional ups and downs during the 2-week wait. And we know that people can sort of, veer from feeling wildly optimistic. And I think one of the things that we also wanted to cover in that question was about the idea of having a fertile mind. There are quite a lot of people out there now who are saying that people need to have a fertile mind in order to help them conceive. And I wonder what you felt about that.
I think that sounds very kind of idealistic, doesn't it? I think the reality is whatever we're talking about, that you need to be able to encompass all aspects of your mind in order to get you through the 2-week wait. My experience of speaking with individuals and couples is that they want to be balancing positivity with realism about what can potentially happen. And I think the fertile mind will be nourished by the healthy eating, by the exercise that's appropriate, by connecting with nature. I think we also need to be mindful, she says, that the fertile mind is about our sense of positivity and hope, and also negotiating, as you said, the kind of pendulum of conflicting emotions that can sit within us, hope and fear, being terrified and also being kind of contented. We're constantly sort of negotiating the emotional minefield, aren't we, of the fertility world. And I think somebody I spoke to, it talked about like flip-flopping, so that sometimes you can feel one way and then it feels like apparently for no reason that state of mind can flip. It's kind of accepting that there will be an emotional response. It's being mindful of that emotional response, whether it's fear, whether it's anxiety, whether it's hopefulness, and to be able to sit with them. Often the emotions that are brought, aren't they, are the kind of more challenging emotions, such as being scared, such as feeling vulnerable, such as feeling kind of heightened and extra sensitive to what's happening, and allowing those emotions to kind of resonate, also being mindful that they will pass. We can't emotion proof ourselves, can we, going through the fertility treatment? But what we can do is recognise the emotions, look at what we can do in order to kind of self-soothe and ease those. That's the best thing we can do, and actually accept all parts of ourselves, and not to try and shut down or suppress emotions that sometimes we're not kind of comfortable with. Sometimes emotions can look like jealousy, sometimes emotions can feel like guilt, sometimes emotions can be around shame, sometimes emotions can be around some of the things that we don't always want to kind of voice. It's kind of accepting that we're human and we have all of those emotions. They will come into our mind, and it's how we deal with them at that moment in time, that they will pass. And then in order to be able to kind of enforce or encourage the softer emotions about that you are doing the best that you can, that you're a good person, that this isn't something that you would have wished upon yourself. It's trying to be gentle with yourself in order to give yourself the encouragement and the confidence to go through treatment, whether it's your first, second, third, however many times it is, because we know that there's an element of anticipatory anxiety, especially when it's not your first treatment cycle. And recognising in all of that there's loss and grief, and some of the loss and grief is visible and some of it's invisible, but that's part of what we do when we go through fertility treatment, is grieving potentially different things within ourselves that aren't always visible and aren't always spoken.
Thanks, Deborah. Thanks. That's really useful. Ephia, I had a question for you, which is, does the level of HCG in the blood test after the 2-week wait give any indication of the viability of the pregnancy?
The straightforward answer is yes. If at the time, if it's not done too early, a very low level, so because even a concentration as much as 20 could lead to a positive test. So if it was 20, 14 days after embryo transfer, so that is a low level and will be worrisome. And an extremely high level could also suggest an abnormality, such as a condition called trophoblastic disease. Okay, so, but within normality, there is a huge range. So it is very important to appreciate that within normality, there's a huge range, and they are all normal. And of course, if someone's had double embryo transfer and it's led to a twin pregnancy, they will have more HCG at the same time compared with a singleton pregnancy done at the same time. So yes, but this level is not for interpretation by a layperson. So any level, whether it or the implications of a certain concentration of HCG is a clinical matter. It needs to be assessed in reference to several other things, such as what time it was taken.
Thanks, that's really helpful. I think there's often a tendency to try to make sense of hormone levels at home, and I think it's a good lesson that sometimes we may not be able to. Debbie, there's a question for you. After someone asking about the need to keep warm, someone else is asking about whether they should be avoiding hot showers, and is that true, and is it limited to showers, or should you avoid getting hot full stop?
No. That is a bit of a fallacy. I think, like anything, you're not going to put yourself into a boiling hot bath or a freezing cold shower. Be at normal temperatures, in the same way that using strong aromatherapy type oils that do have issues around early pregnancy issues and problems. just look up, just any products that you're going to use, look up and make sure that they're safe in early pregnancies, because we're at the fertility centre, we're not the experts in what products, etc., that you can use. But as for hot or cold showers, normal temperature. That's the simple answer.
And baths, can you have baths? Because sometimes people are worried about having a bath.
Yes, you can have baths, but again, a normal temperature, not too hot, not too cold, and just be careful of the products that you're using within the baths. There are some strong aromatherapy oils that are said to have issues around early pregnancy loss. So, be careful, but I'm not the expert on those. I don't think any of us are here around the table tonight. So, be cautious, be conscious of what you're putting in there.
You've got another question that's just sort of slightly related to that, which is in terms of heat on the belly, is this something to avoid? It's rather sweet. My dog likes to snuggle in. I found the last cycle he was more attached to do this more. I mean, is that okay?
If that's something that you normally do and that's how you normally react, then yes, I think that's absolutely okay.
Brilliant. Thanks very much. One question which I think maybe would go to Ephia is around alternative complementary therapies, and are there therapies that people should be doing during the 2-week wait? I know a lot of people do acupuncture, and sometimes people think that they need to do acupuncture. I just wondered if you had any thoughts, Ephia, on complementary alternative therapies during the 2-week wait.
So firstly, the term alternative or complementary, so it does suggest that it is outside the remit of the, my practice of medicine or these or us clinicians. However, there are certain, again, you judge based on the knowledge of what that therapy is. So you mentioned acupuncture, Kate. So in acupuncture, it is something mechanical, some stimulation. I can see no harm. Okay, so it's on the basis, should you do it? No. Then, is it a case of that only people who have acupuncture have higher success rates? No, that has not been proven. But if it makes you feel better, if it also allays somewhat your anxiety around the 2-week wait, or even earlier, or or the 2-week wait, by all means. With regards to certain supplements or herbal remedies, now that I would say no to, because I don't know what is contained within it. There may be some active ingredients. Just like Debbie said, if a certain product in the bath has a certain active ingredient and it can react. Now, because we don't know what these are, it will be difficult to tell. In terms of skin, I'll just give an example. This is not an alternative therapy, but anything that contains retinol isn't therefore a good idea, because we know retinol can be, have adverse influence on an early pregnancy. So just as an aside, but these alternative therapies depend on what they are. If they are mechanical, I don't see a problem. If they are expensive, again, use your own judgment. Again, you see the value, right? If you see that there is a value in that, and as long as it does no harm, by all means, go for it. But if you are doing it to the detriment of, your finances, or there is, and therefore, you're weighing up risks and benefits, and any benefit, like the risks could actually be higher than the benefits, then the answer is no. In general, to then give you a sort of a steer, it's not great to combine different therapies, especially if it is something you consume, because again, you don't, they might be in competition, you don't know. So for example, a certain product, sometimes products that are supposed to enhance fertility may actually be anti-estrogen, because like clomiphene, because it's anti-estrogen, it elevates certain hormones that might trigger ovulation. Okay, it might be those kind, and therefore they may be competing. So one has to be careful and exercise judgment.
Thanks, Ephia. Debbie, we've got a question about whether you should rest for a few days after embryo transfer, and that kind of ties in with another question that we had earlier about working after embryo transfer and whether it's okay to go back to work and how soon you should go back to work. And I wondered if you could answer that for us.
There's the $1 million question, and we get asked it every single couple that comes through, I'm sure. There is no right or wrong. And I think just do what you normally naturally do. Some people need to take 2 weeks off for that 2 week wait and go on a holiday and completely distract themselves. Some people just want to engulf themselves in their work. I think do what you think is best for you. And as Deborah's alluded to, don't beat yourself up. Be kind to yourself. There is no right or wrong here. It purely is about what is going to make you feel best. And if that means going and having some reflexology or acupuncture, whatever it might be, then do that to help support you through that 2 week wait. Do not beat yourself up over this. From a clinical perspective, we still haven't got it right. We're still talking. I've been doing fertility for over 25 years, and we're still talking about how we support you through this 2 week wait, because there is no right or wrong answer. And from the clinic perspective, we just need to let you know that we're here for you. Call us, ring your counsellor, ring your nurses, talk to them. I'm not going to exclude our clinicians, but as Ephia said, they don't come into that bit so much in that 2 week wait, but that's what we're there for. And, we've tried over the years to give you a call a week in, see how you're doing, what's going on, anything we can do to help. And some people get opposed to that. They don't want that call. So we back off and we leave it to you to come to us, but use us. That's what we're there for. There's no right or wrong. Be kind to yourself and do what is best for you in that 2 week wait. So go to work, go on holiday. I'm not going to advise you either way. Do what's best for you.
Thanks, Debbie. And one other question around what is the earliest you recommend taking a pregnancy test? I think we've sort of covered this a bit, but I think it's really important to get a clear answer again around when you should take a pregnancy test.
I think the easiest explanation I give to my patients now, because we do embryo transfers at different dates, different times, is to do it 2 weeks after your egg collection. So you count your egg collection as you've ovulated. 2 weeks later, you should be doing a pregnancy test as you would be doing naturally, normally, if you were expecting your period 2 weeks after you've ovulated. So I think that's the easiest. 2 weeks after your egg collection, that should be the earliest. Lots of clinics will do different things, and you'll do 4+2 or 4+4. Go be guided by your clinic, but do not test any earlier than 14 days after your egg collection, because you're going to get a false negative or even, a false positive. You need to make sure that you're doing it at the correct time. So that's the earliest you should do it.
Thanks, Debbie. I think, Ephia, you wanted to come in on that one as well.
Yes, I just wanted to add to say, do the pregnancy test at the time your clinic is advising you to do, because there are other things, apart from being positive, negative, there is the interpretation of results. So everything is, there are people work to certain protocols. So the advice they give you about the level, etc., it's more sort of accurate when it is done at a time that the clinic has worked out and has based their protocols on, because there's nothing to be gained by doing them earlier.
Thanks, Ephia. I actually had another question for you here from someone who said they had a very good quality early blastocyst transfer, and what would be the main reasons for that to be unsuccessful?
Sorry, is that for me? Yeah, okay. So, well, this is actually the more common occurrence of any fertility treatment, that despite everything being textbook, such as the development of the lining of the womb, the response to medication, the number of eggs collected, blastocyst development, and yet the pregnancy test is negative. Even in kind of the best case scenario, about half of all cycles will be negative. And often it is difficult to say exactly why that is the case, because as I was saying about what happens, that there is this cascade of events. There is all this signaling that has to go on, and everything has to be just so. When anything in that process is slightly off, then a pregnancy will not occur. Now, that doesn't mean it will not occur another time in another attempt, especially if you are getting good quality blastocysts, because there is such a thing as what we call cumulative pregnancy rate. Like even in the best case scenario, even in natural pregnancies, it's not possible to get pregnant every time someone tries. So even a 20-year-old will not get pregnant the first time they try. So pregnancy is always a matter of chance. Okay, so yes, we need to look into if that has happened, what was the endometrium, okay, and anything else. But there is nothing external in the sense like, oh, I had pain or I had a particular type of food. There is nothing of that sort because it is an event neither the patients nor the embryologists, clinicians, nurses can control.
Thanks. We've got another question that's kind of slightly related to that from someone who said that they had a lot of pain in the first week after an early blastocyst transfer, felt very tired, achy, and had pain seemingly everywhere, even in their legs. Their transfer was unsuccessful, and would the pain have been a factor in that unsuccessful cycle?
That's an interesting question in the sense, I'm just looking at those, I'm hearing those symptoms and I think, okay, aches and pains everywhere, feeling excessively tired. Was it a viral infection? We don't know. But having said that, you see, it's quite difficult. If a pregnancy were to occur, it is quite difficult to interrupt that process, even in, quite extreme circumstances. And my straightforward answer would be that it's very unlikely that those aches and pains and feeling unwell. But I'm just trying to think if it was something that has never been experienced before with an embryo transfer and why it happened at that time. Now, just to address one thing, sometimes after embryo transfer, if there is a lot of cramping or pain, again, it's difficult to tell yes or no, but that isn't a good sign in the sense, because when we do embryo transfers as clinicians, we make sure the catheter never touches the top of the uterus, which is the fundus, where and it has to be as smooth as possible. So if it was a very difficult transfer and there were several attempts and that led to a lot of pain, that could be an element. A difficult embryo transfer could be a factor. So it's not a straightforward yes or no, but it depends why. But a straightforward embryo transfer in the right location and some cramps or a bit of, but aches and pains everywhere is not linked, is not going to be linked to the uterus itself. But just the symptoms seem to be that of some inflammatory process. So it is difficult to say. I cannot put my hand on heart and say that had nothing to do with it, but I don't know. But it seems to have been there for only 1 week. So was it a viral infection? But if there was inflammation or infection, yes, that's not a conducive sort of state for any pregnancy or the continuation of pregnancy. But as I said, if the process has started, it takes a lot to disrupt that process.
So also it's probably something, given what you're saying, that people should be discussing with their own clinician who knows their own history and what's been happening to them, rather than us being able to answer it here, probably.
Yeah. Can I actually add in I was thinking about these questions and say, in that 2 week, ask all the questions. There is no such thing as an irrelevant question. So even if you think, if something's coming into your head and you think, I want to check this, go ahead and check it.
Thanks. I think that's a really important message. And if there's one thing we'd like you to take away from today, I think it probably is that do ask, don't feel afraid to ask. Your clinic are not going to get cross if you're asking questions. Debbie, a question for you from someone whose BMI is currently 33 and has had an unsuccessful fresh and frozen transfer, has lost some weight, but could the BMI of 33 have been one of the reasons for the transfers not working?
Oh, BMI is that $1 million debate that's gone on and on and on. It is the only tool that we do use with infertility, but we all know that somebody with a very muscular person that's got a higher BMI is not unfit or unhealthy. However, I talk about the fertility road and getting yourself into that best physical shape before you start your treatment. And as you're starting your treatment, you're in that best place. So optimizing your BMI, making sure that it's in the best place it could be. Being too obese or being too underweight can have impacts on your fertility, can upset the hormone cycle and will upset the hormone cycle. So get yourself into that best place and then you're optimizing your chances of getting yourself pregnant. So I'm not going to talk about numbers because a BMI of 33 for one person is going to be very different for somebody else. So talk to your clinicians, get advice and get support from your medical team or your GP to get you into that best physical shape for you.
Thanks. And just while you're there, a couple of other questions about other medications. So someone asking if it's okay to use thrush treatment creams during the 2-week wait. Someone else saying they're currently on antibiotics for a kidney infection and meant to be starting a frozen transfer on the cycle. I mean, what is the situation as regards other medications?
So again, take advice from your clinician. So if you're being prescribed antibiotics, you have an infection that could cause many more problems if you don't treat that infection. So, take advice from your clinicians, tell them that you're having fertility treatment or that you're waiting for your pregnancy test. Let them know, and then they can perhaps advise on the best antibiotic that's more acceptable for early pregnancy. But don't wait to get treated. Treat those symptoms. And the same with thrush. Again, get advice. And if you do need to be treated, then get yourself treated.
Thanks, Debbie. We're coming to the end of our webinar this evening, and what I thought it might be quite useful to do at the end is just to get everyone to summarise maybe what they would say to someone going through the 2-week wait, what their key piece of advice might be. Debbie, since you're there, would you like to go first with yours? What would you say to people about the 2-week wait?
I think I've said it a few times this evening. Don't beat yourself up. There's no right or wrong in what you should or you shouldn't do. Just do what you feel is best for you and your partner in this scenario so that you can get the best out of that 2-week wait. It's horrible. We know it is. As Ephia alluded to earlier, you've gone through where you've spent a lot of time with the clinicians, the nurses, the counsellors to get yourself to that embryo transfer, and then suddenly you're left out on your own. You are not alone. Call your clinic, speak to your nurses, speak to your counsellors. That's what we are there for. And that's the service that you should be getting from any clinic that you're attending.
Thanks, Debbie. Ephia, would you have a closing comment?
Yes, what I would like to say is that, one, it is easier said than done, but we need to tread that fine line between being realistic and accepting that IVF or any fertility treatment, it doesn't always work. In fact, in the best case scenario, as I said, it might work about 50% of the time. So accepting that, but at the same time, obviously, to remain hopeful, try to, control what can be controlled, such as diet and exercise and getting oneself in the best possible place, but also accepting that there are some things beyond anybody's control. And that 2-week wait is one of them. And so is pregnancy, during pregnancy. Sometimes pregnancies are very smooth. Sometimes they are quite difficult and challenging. But it's not because somebody has done something, but the body does sometimes respond in certain ways that we do not have exact explanations for. Sometimes we do, sometimes we don't. So it's about that fine line, getting oneself armed with the knowledge and asking all the questions, getting yourself in a good place, but to try and not be sort of over aware of that 2-week wait. I know, again, as I said, it is easier said than done because you have the time. It's like, gone through all of that. And of course, we would want a positive test. And also, please remember that here at this end, our counseling colleagues, nurses, and clinicians, we all root for you because what you want is what we want. We also want success. And we will be doing everything within our means. It is a collaborative process. So ask the questions, seek answers, but also accept that there isn't an answer for everything.
Thanks, Ephia. And Deborah, I wonder about a brief concluding word from you about what you'd like to tell people.
Okay. I think it's having your backpack prepared really with what you might need in that. So if you need to be able to reach out and speak to somebody, whether it's a counsellor, a partner, a member of the family, whether it's a friend that you can sort of look around in your rucksack of sort of support. Also being mindful about whether you need to take that time out and to have some alone time to process whatever it is you're processing, whether it is that you need to go to work, whether it is you need to go on a walk, whether it or not it is that you need to kind of keep yourself hydrated, keep yourself connected, whether or not there's a higher being that's in your, you know, your life, your spiritual side, religion, whether or not there is something in your backpack that you kind of have to look in there and find you in all of that. And as you know, Debbie said, and Ephia said, it's being kind to yourselves, and it's being reassuring that you are absolutely doing the best that you can do in the time that you're given with the circumstances that you're given. And as Ephia said, we all do really hold on to hope and faith that, you know, we want, like Ephia said, what you want for there to be a successful treatment for you all, and to and to kind of approach your clinic, approach the nurses, approach the embryologists, approach the counsellors if there are any questions, to communicate what the worry is, because if there's a worry there'll be a whole bunch of other worries. So it's kind of taking that first step to contact the clinics if you've got a worry.
Thanks so much, Deborah, and thanks to Debbie, and thanks to Ephia, and thanks to all of you as well for joining us this evening. You'll be able to find the recording on the webinars page on our website in the next couple of days, but in the meantime, don't forget that we're here for you too. All our services are free of charge. We've got groups right across the UK, and our support line is open every weekday. So do get in touch with us if you need any kind of help or support. So thank you to everyone. I hope this has been useful, and thank you so much for joining us this evening.